My name is Dr. Amit Abraham. I'm an assistant professor here at Weill Cornell Medicine in Qatar. This is the first webinar series of the year of 2026, and we are really excited for the session today. A few ground rules before we begin. So about the wellness series, the overall aim of the series is to try to create and raise community awareness about health and disease. And the objective is to try to enhance self-care, reduce suffering, improve quality of life, and increase healthy longevity. And please do note that this is not a CME CPD activity. So the target audience for this series is the general public. A few ground rules before we begin, housekeeping rules. Please note that your cameras and your microphones have been switched off. If you have any questions or comments you'd like to share with us, you can either use the Q&A feature or the chat. Any questions and comments will be addressed at the end of the session. I will be moderating the session with our speaker. And just to reiterate, this is not a CME CPD activity, so there will not be any certificates of attendance issued at the end of the session. So I am delighted to introduce our guest speaker for today, Dr. Hala Mohamed Moussa, who is a pediatric neurologist at Sinai Hospital, Baltimore in the US. And she's going to be talking about epilepsy in kids, breaking down barriers and building understanding. So let me give a brief bio about Dr. Hala, who, by the way, is one of our alumni. She graduated from Weill Cornell Medicine-Qatar. So Dr. Hala Mohamed Moussa is a board-certified pediatric neurologist who has extensive clinical experience across both the US and Africa, with a specialized focus on complex neurological disorders in children. With the notable achievement of founding and leading Mauritania's first pediatric neurology service, Dr. Moussa has actively engaged in research partnerships with prestigious institutions, including Baylor Genetics and UNC Neurosurgery. She is dedicated to medical education, mentoring students at Johns Hopkins and George Washington University, and providing clinical care at Sinai Hospital. Fluent in multiple languages, she effectively serves a diverse patient population. Dr. Moussa's impressive professional background includes serving as the chief of pediatric neurology at the Centre Hospitalier des Spécialités in Mauritania. I hope I pronounced that correctly, where she's established the nation's first pediatric neurology department and developed the first collaborative neurodevelopmental clinic for the neonatal intensive care unit graduates. Her academic roles include assistant professor and instructor in clinical pediatrics, and she has participated in significant research projects, contributing to cross-continental efforts in genetic disorders. Committed to humanitarian work, she has led initiatives for autism diagnosis and care, organized training programs for physicians, and participated in medical missions, emphasizing her leadership in both clinical and global health domains. Dr. Hala, the floor is yours. Thank you so much.
Thank you, Dr. Abraham, for that generous introduction. I'm going to go ahead and first share my slides here. So good afternoon to you and good morning on this side of the world. So I'm delighted to have this opportunity to talk about epilepsy in kids, where we can hopefully break barriers by building understanding. Before I start, I wanted to get a general sense of where people's understanding of some of the general things or general key concepts around epilepsy are. So I wanted to start with a few poll questions. So the first one is epilepsy and seizures. Do they mean the same thing? Epilepsy and seizures mean the same thing? Yes, no, or I don't know. Okay, perfect. Awesome. All right. Now, the next question. So can doctors give treatment to control your seizures even if they do not know the exact cause of the epilepsy? Yes, no, I don't know. Perfect. All right, and then we have a third question. All seizures coming from the same lobe, so part of the brain, look the same. True, false, not sure. Okay, awesome. All right. And then our final question is people with epilepsy need stricter, I guess I'll wait for it to come up. People with epilepsy need stricter rules for going to school, playing tag with friends, riding a bike, or driving a car. Obviously, if you're driving a car, probably or older than 18, hopefully. But okay, awesome. All right, wonderful. Okay, so thank you for all of you for participating. This gives us a good start. Um, and so I want to first start off with asking ourselves the question of why should we care about this diagnosis? So from our perspective as clinicians, the reason that we care is it is the most common chronic neurological disease in children. So you can imagine that about 50% of the patients that come through to our clinic come with concerns of possible seizures. In the US, it affects approximately 1 in 26 people, and worldwide, the estimate is 96 million people, which I believe is an underestimate. Having practiced as the only pediatric neurologist in Mauritania, I was inundated with children that were had a diagnosis with epilepsy. And why it is important in this pediatric age group is that peak prevalence for epilepsy occurs in those early childhood years, between 5 and 9 years of age. In terms of why you should care as a non-clinician, maybe you have a member in your family that is affected by epilepsy or someone close to you. And inevitably, with an approximate estimate of 1 in 26 people, I think it is safe to say that every one of us either has someone close to them has had epilepsy or knows of someone that has had epilepsy. So when we are trying to navigate a concept, I think it is important for us to ask key questions. So when I was preparing these questions, I took it from the perspective of my patients. What are some of the questions that they struggled the most to grapple with? And what are some of the things that I had to take the opportunity to go in more detail and in more depth to try to get them to a closer understanding, a closer acceptance, a closer ability to make a shared decision about the treatment plan for their child. And so I think the first key question is, what is epilepsy? How do we define it? How do we diagnose it? What causes epilepsy? How do we treat it? And what is the outlook in general for children with epilepsy? So those are the questions that I hope to answer with this presentation. So before we go into what is epilepsy, we need to understand what are seizures, because the term seizures is incorporated into the definition of epilepsy. So it's very critical for someone to understand what seizures are. So the brain has cells that we call neurons that are able to communicate with each other through electrical signals. And they are housed in particular networks in the brain. And when these neurons have a surge of abnormal brain activity all at once, they can result in a short-lived episode. And we think of seizures as either provoked, that there's been a trigger like an infection or a significant fall, or unprovoked, that they've happened kind of out of the blue. And this is key to understanding the definition of epilepsy. So what happens during a seizure? So what essentially occurs during a seizure, which we'll go into further detail later in the presentation, kind of depends on where they are in the brain. A lot of times in the seizures that maybe most of us are familiar with, where there is full body shaking seizures, there may be changes in what we call vital signs, which is like heart rate or breathing patterns, etc. And because the brain has had this sudden surge of electrical rhythm, it will get fatigued. And so oftentimes patients will appear sleepy and feel lousy after the seizure. Now, what causes this seizure? So again, the key term here is seizure and not epilepsy. So when you have a patient coming in with a first lifetime seizure, you're going to have to, in your attempt to try to understand the cause, go through looking for infectious causes, brain infections can cause it, looking for, is there some kind of injury to the brain, like a bleeding in the brain, a neurological cause? Is there some changes in the sodium, calcium, magnesium? And then ingestion of toxins, which is really important in children, especially when you're looking at toddlers that get into everything that may get into their parents' blood pressure or diabetes medication, etc. And then one thing that we have to look into is the possibility of epilepsy being the cause of this first lifetime seizure. So what is epilepsy? And I want to take some time to go through the definition because I think it's very important to understand it, and it will take away some of the mystery or some of the misconceptions that we need to have a certain test be positive to have the diagnosis of epilepsy, which is not the case. So first and foremost, it's a clinical diagnosis. And when we use the term clinical as physicians, we mean it is based on the history that we gather and the physical exam that we perform. We don't need a blood test or a picture or any kind of fancy testing to establish that diagnosis. It can be helpful to further the diagnosis, but not to establish it. And the definition includes 2 or more unprovoked seizures that are greater than 24 hours apart, or you can have 1 seizure and a risk factor. So when we use the term as clinicians risk factor, what we mean is the things that increase our chances of another seizure occurring. So essentially, when you sit back and look at the definition of epilepsy, all it is telling you is that this is a patient in front of you, this is a child in front of you that is at risk for having more seizures. So all epilepsy tells you, we are at risk of having more seizures that are coming, if we don't treat them, and that treatment is essential. So what are some of the risk factors? So some of the risk factors is having an abnormal brain rhythm pattern on EEG, which is the electrical rhythm test for the brain, or a structural change in the MRI. The key here is that structural change has to be an area that has a seizure tendency, an area of the brain that can produce seizures. So that's important because sometimes we can have quote unquote abnormal MRI, but the abnormality is not within those areas that produce seizures. A first-degree family history of epilepsy. So either parents have epilepsy or their sibling has epilepsy. A genetic finding, especially in this day and age, genetic testing, whole exome sequencing, whole genome sequencing are becoming more accessible and are informing our care more and more. And then lastly, especially in children, the focus is there is greater risk on neurodevelopmental delays like autism or global developmental delays or cerebral palsy, in and of itself being a risk factor. Okay, so getting a diagnosis. So the first visit with your neurologist is going to involve the neurologist extracting all the details that they can of the episode and what it looked like. So witness accounts are the most important. Capturing the episode by the family is very immensely helpful, obviously, when we can do it in a safe manner. And then reviewing the child's birth history, because we're looking for risk factors. Was the child premature? Development, are there some underlying developmental delays maybe that are undiagnosed? And obviously family history of seizures. And examination, a very detailed neurological exam is going to be imperative, including the skin exam for specific birthmarks. So getting a diagnosis, testing options. As we mentioned earlier, epilepsy is a clinical diagnosis, so there's no single test. But there are tests that are helpful to furthering that diagnosis and looking at risk factors. So one that almost all patients with seizures will end up having at one point or another is the electroencephalogram, which is a study of the brainwave patterns. And certain brainwave patterns clue us into certain epilepsy syndromes or epilepsy diagnoses. And the other one, which is optional depending on the seizure type. So not all patients, not all children with epilepsy have to have an MRI. It depends on the history and the EEG findings. And that's looking only at structure. And I want to spend a little time on this because I think it's very, very key, because I find a lot of my patients' families struggle with the idea that the MRI is normal. Oh, Dr. Moussa, the picture of the brain is normal. How can it be that my child has epilepsy, especially if the EEG is also normal? And that's another thing that I forgot to mention is 50% of the time, the 30 to 40-minute study, the routine EEG is going to come back normal. And the EEG is limited in the sense that one example I give patients, it is a short study, it's short-lived. If you were, for example, if you were on a highway in front of QF and you were trying to check for 30 or 40 minutes if there is a green car in all of Doha, and you had just that 30, 40-minute period, if the green cars are not common, there's a high chance that you might not capture it. So there are limitations depending on how often those seizure tendency markers show up, and also limitations in the sense how deep those seizure tendency markers are, because EEG at the end of the day is a surface test. It's not deep within the brain kind of test. And then genetic and metabolic testing, especially genetic testing, is becoming much more accessible and much more informative of our care, even sometimes medication choices. And rarely, there's a subset of patients, especially if they end up getting admitted and they have these really horrible seizures that are very difficult to control, we may consider things such as autoimmune causes affecting the brain. What causes epilepsy? So, like we said, epilepsy is a clinical diagnosis. It looks at seizure tendency risk. So it's an umbrella term. And so there's no single cause. There are multiple causes if they're known, but more commonly, the cause is unknown. Up to 50% of patients with epilepsy, we have no identifiable cause. Among the ones that we do have a cause, usually the cause is related to either a structural brain abnormality, that could be a tumor, that could be an abnormal blood vessel, that could be the brain development was abnormal. It could be a sequela of brain injury, meaning someone had an infection years ago affecting their brain, and that infection caused an alteration either in the structure or the brain networks that led to the development of epilepsy, or an old stroke that years down the line led to the development of epilepsy, or a head trauma that happened again years, months ago that led to the development of epilepsy, et cetera, et cetera. So sequela of brain injury is one cause that we look into. And then autoimmune brain inflammation and genetic metabolic causes. So I want to spend quite some time on an interesting aspect of epilepsy and seizures, in terms of what do seizures look like, and take away the mystery about why seizures can look different and how do they look different, how can we recognize them early, etc. I think most of us are familiar with the classic type of seizure where eyes are rolling up, stiffening, and full body shaking seizures. But seizures actually can look pretty subtle. And so I want to spend some time around this and create awareness so people are able to recognize things earlier. So why do seizures look different? The reason seizures look different is because our brain is responsible for so many different functions. And we generally think of the different parts of our brain as four different lobes. And each of these lobes are inundated with several more functions. So even within each lobe, there can be various functions depending on the area. So as an example, the occipital lobe is involved in sight and visual perception. So seizures that are coming from this area often have loss of vision, or what we call a visual hallucination, in the sense that there's this sudden color change that occurs prior to the event. Whereas frontal lobe seizures may have more abnormal behavior or abnormal movements or abnormal eye movements, et cetera, related to that, or posturing, and so on and so forth. So depending on where in that particular lobe the seizure is arising from. And then there is the full generalized seizure covering the whole brain, which I will cover here. So when we're classifying seizures in epilepsy, they can be grouped into, we can either tell that they are generalized, meaning that when these seizures happen or when the surge of abnormal brain activity happens, it happens all at once throughout the brain. Or it is a focal seizure, meaning that that surge of abnormal electrical activity starts in one particular area of the brain. Or sometimes we're unsure. It looks like a generalized seizure, but maybe we're seeing some markers on the EEG that tell us that it is coming from a particular focus. So sometimes it can be uncertain. So what do seizures look like? So there are four different, I guess, patterns you can think of. One is changes in awareness, abnormal movement, changes in behavior, and odd senses. So we'll go through each of those. Now, the key feature to keep in mind when it comes to seizures and epilepsy and differentiating it from other conditions that can mimic seizures is that they're brief. They're usually lasting seconds to less than 5 minutes. They have a cookie cutter pattern. That means it looks like a replay of the same thing almost. They usually have some changes after the event, not every single time, not with every seizure type, but often after the event, there's some confusion, fatigue, etc. So when seizures present themselves as changes in awareness, they can often be mistaken for daydreaming in children, ADHD, where they're not listening. And the way they present themselves is a child may have a sudden pause, blank stare, becomes unresponsive. And this can be really brief and occur multiple times throughout the day. Or they can freeze, space out, they're talking to you, stop mid-sentence, recover, continue what they're talking about. Or mid-movement, they were walking and they stop in their footsteps. Or maybe after a brief pause, the child acts a little lost or confused when they come back. So what families can watch for is trying to see if they fail to respond when touched. But sometimes these episodes are so brief that it's hard to tell if your touch is what helped recover the patient or the seizure itself was so brief in the moment. Does the episode interrupt talking or activity? I think this is the most important. Is there a complete arrest of behavior? Like there's no movement at all that happens when the episode arises. Does it last only a few seconds, but then repeat itself like in a cookie cutter fashion multiple times? And these typically occur with a generalized kind of epilepsy we call absence epilepsy, or in focal impaired awareness epilepsy, which is a focal kind of epilepsy. Now, the other way seizures can manifest themselves is, and these may be obvious or subtle, is observable motor movements. This is the one maybe we're more familiar with, full body shaking, etc. But then there are more subtle ways that motor movements can happen. So we know the full body stiffening, jerking, which we call a generalized tonic-clonic seizure. Now the twitching can be from one side of the face or arm, and that can clue us into that the seizure is coming from one particular area of the brain. Or it could be that the child loses the ability to control their muscles completely and drops and collapses, which are atonic seizure, and those are seizures that put kids at high risk for injury. Or the movements can be just purposeless movements, lip smacking, finger rubbing movements. What families can watch for, are they rhythmic, they're repetitive? It is helpful in the subtle ones to try to capture the video. Does the child retain awareness or lose it? This is important information for the clinician to try to understand your seizures better. And does movements start in one part of the body and spread, which is also important for understanding the seizures. Now, the third way seizures can present, and this is often overlooked and mistaken as just a behavioral issue or just an odd behavior, which is a sudden behavioral or emotional change. Some examples, child kind of acts fearfully out of the blue without a trigger, running toward the caregiver. This may precede a seizure, like a full-blown full body shaking seizure. Or there's such a thing as laughing seizures, call them gelastic seizures is the medical term. And that's just abrupt laughter that doesn't match the situation. Often in children, often presenting in toddlers more commonly. And this is different from the unshared laughter that can happen with autism spectrum disorder. So it's important to try to capture a video or capture those episodes on EEG to try to understand them better. Now, random Wandering or picking at clothing can also happen with sometimes frontal lobe seizures. So the key thing about these behavioral emotional changes, they're brief. And I think this is an important thing to illustrate because when your doctor's trying to decipher are these seizures or not, there are other things that can cause behavioral and emotional changes that are more psychiatric. And so that becomes important. All right. Okay. So sensory changes, we think of them as auras. So those are better described by our older children and teens. And the examples are a rising feeling in the stomach, almost like a nauseous kind of feeling, a sudden strange taste or smell, a tingling in one part of the body, a distorted sound or visual change, a déjà vu, a jamais vu, meaning it's like they go into the situation, they're like, it's as if I've been there before, or jamais vu, they come into a familiar place or situation and they act as if they've never seen this before, never seen this person, or never been in this place before. And these auras are usually little mini seizures that precede a more full-blown seizure. Finally, your after seizure clues, which we call post-ictal signs. Ictal just means the event, so post-event, which was a seizure, so post-seizure signs. Sometimes the sign you notice is what happens after the seizure. And that's actually often the case with my patients, is that families will tell me, well, one day my child woke up to get ready for school and they just acted odd and strange and didn't know how to brush their teeth or, change their clothes. And I didn't think much of it until this, big episode happened. So sometimes they've had a seizure in the middle of the night that went unnoticed. The after seizure signs is what the family notices in the morning. So confusion or grogginess, headache or vomiting, difficulty speaking or understanding words, sleepiness, irritability. And the reason these after seizure signs occur is when you have that sudden surge of electrical activity, you can assume that the brain gets fatigued in some ways. And so as it's trying to regain its normal electrical balance, and it's not quite there yet, it's not working at full capacity. And so that's where the grogginess, the tiredness, and depending on where the seizure was, maybe difficulty articulating if it was in the temporal lobe, or even sometimes a weakness that resembles a stroke and can be very scary in the moment. I'm not going to go into detail about different childhood epilepsy types by age, but I just wanted to illustrate it for everyone that we do think about epilepsy kind of as I guess the most common epilepsy syndromes in different age groups will differ based on each age group. And I think that's more of an important thing for us as clinicians. I think as general public, as parents, it doesn't matter to them as much. What matters to them is what their child is going through. But this is just something to keep in mind. And then also to keep in mind that I am not covering infants, which are a whole different ball game of different seizure types. Maybe a future talk I can do that. So you've established the diagnosis of epilepsy through clinical diagnosis. Maybe the EEG was normal, maybe it was positive. Now, what's next? So in most cases, the next step is anti-seizure medications. And anti-seizure medications are an option for most epilepsy. Rarely in children are there some self-limited epilepsies where we have a shared decision with the family where we don't need to start those medications, but that's a very rare scenario. And then there are seizures that are a little bit more medication resistant. epilepsies that require other considerations that I can't go into a lot of detail about today, but happy to answer questions. Dietary therapies such as ketogenic diet, a consideration in certain epilepsy syndromes, especially genetic ones. Epilepsy surgery is a promising method for a lot of our patients that are suffering with drug-resistant epilepsy. And then brain stimulation devices are more of what we consider a palliative approach for patients that are having numerous seizures, such as VNS. Now, treatment outcome, many childhood epilepsies have excellent outcomes. We cannot generalize. It's a very nuanced conversation, but in general, in a child that's developmentally normal, especially in that school-age children, when they present with epilepsies and have no developmental concerns, then 70 to 80% are able to achieve good seizure control on a single medication. There's that 20 to 30% of epilepsies that are medication resistant. And the choice and the duration of the seizure medication varies, but as a general rule, again, in that childhood phase, usually if they're 2 years seizure-free, we have a shared conversation after EEG about weaning off the medication. So living with epilepsy, I'll try to go through this a little bit more quicker because of time. So children can participate in most activities. They have to adhere to seizure precautions. Family support is crucial. Teaching the siblings of the child with the epilepsy about their diagnosis, having a supportive teacher, a supportive classmates that understand, I think, is very crucial. And then regular longitudinal follow-up with specialists is important. I tell all my patients that this diagnosis is a dynamic one. What I can share with you or my understanding of what is happening now is based on the information I have now. Sometimes there's additional testing that we have to do. Sometimes we have to see how it plays out, because sometimes seizures or epilepsy, there's a honeymoon phase where they respond to medication beautifully, and then suddenly we get more seizures and we get more of a drug-resistant epilepsy. So seizure precautions, I won't have the ability to go through each of them in detail, but you have to think about water safety, meaning one-to-one supervision for like swimming, fire safety. So for your older teens, if they're preparing their own food at the stove, just making sure someone is beside them, or perhaps microwave or heat their food instead of using, the direct stove. Just thinking of what if something would happen to keep them safe from, hurting themselves. And then in terms of heights, this is more of a concern if seizures are not as well controlled. So kids that are on playgrounds, monkey bars, and things of that nature, perhaps having a conversation with your physician, should we have the seizures well controlled for 3 months before, they engage in things that could pose harm. And then in terms of activities in general, we think of them low, medium, and high risk. Most low risk activities are safe. Medium risk, such as contact sports, wrestling, football here in the US, those are more of medium risk activities. So we would like to see a better seizure control before we allow patients to engage in those. And then high risk activities is more of like if you're engaging in things like paragliding or probably activities that most pediatric patients are not engaging in. But at the end of the day, there has to be a shared decision that is engaged with your neurologist. And then driving, here in the US, kids start to learn to drive around 15 years and 9 months. So it's an important conversation here. And then reducing stigma centers around peer-led stories, teachers, and school nurses being well-trained to manage and address seizures, creating seizure action plan for the family and school that they can follow. And community storytelling is very important, empowering the child to talk about their seizures, their siblings to talk about the seizures, and caregiver groups. There's a lot of online group supports for different epilepsy diagnoses. So seizure action plan, that's a personalized guide to responding to a child's seizure. It talks about the seizure type, the rescue medication that needs to be used, and the emergency steps. So it gives the families and the school the confidence of how to approach a seizure. So take home points. Epilepsy is a clinical diagnosis. Epilepsy has no single cause. Seizures can look different. Most seizures are brief and repetitive. Most childhood seizures have excellent outcomes. And I don't know if I have time for these clinical scenarios, but maybe I'll go through just a couple. So first one, the invisible seizure. Mariam's teacher reports that she daydreams several times a day at home. Her family notices she stares quietly at the wall while her hands twitch slightly. The episodes last 10 to 15 seconds. So we can see that these are alterations of awareness. They happen several times. They're kind of cookie cutter, stereotypic. They are very brief. So the possibility is it could be a type of generalized seizure called absence, or a focal seizure called focal impaired awareness. And then obviously talking to your clinician and tracking frequency are the next steps. And then the strange behavior seizure. So Jamal suddenly wanders around the room, picking at his shirt, chewing, blinking. He doesn't answer when he calls, so he's unresponsive. After 1 to 2 minutes, he's confused and tired. So there's some post-seizure signs or post-event seizure clues, the confusion and tiredness. He could be mistaken for a child that's just misbehaving or being, silly. But in this scenario, especially if it repeats itself and with the post-event clues, this is probably a focal seizure. So these are my references. I think the most important reference would be the Epilepsy Foundation. It's an excellent resource for families and clinicians alike. And my other reference is my 5 years experience in Mauritania and all the patients that I've treated that have, taught me so much, and the excellent team that I miss to this day and I hope to reunite with them come February in our global health trip. So any questions?
Thank you so much, Dr. Hala, for that very insightful and timely discussion. I want to remind our audience that if you have any questions or comments, please share them in the chat or the Q&A, and we can pose them to Dr. Hala. So I want to start off with a question of my own, because I saw that you did have a slide where you wanted to where you touched on what do we do if someone is having a seizure in front of us? Are there certain do's and perhaps don'ts? So things we do not want to do if we see someone, actively having a seizure.
Yeah, no, that's a very great question. So the things to keep in mind, there are 3 words that we think of: stay safe inside, meaning stay with the patient or the child that's actively having a seizure. If you're able to start a timer, if you have the wherewithal at the moment, make sure that they are safe. So if you have to kind of reposition them to a safer area, that's important, and put them on their side, so that we think of anything, any drooling, anything of that nature. We don't want it to come to cause them any choking or any what we call aspiration. And so position them on their side is all you have to do. Don't put anything in their mouth. They aren't going to swallow their tongue. That's a myth. And if anything, putting anything in their mouth poses risk for them and risk for you. Because when someone's actively having that tonic-clonic seizure, they can bite really, really hard. So yeah, so those are the key things. And then calling emergency services. I don't know, in Qatar, is it 911 still?
999.
999. So calling 999. Um, and yeah, timing the seizure. Majority of seizures last less than 2 minutes, 2 minutes or less. Rarely is it going to be those type of seizures that kind of drag on.
Okay, thank you for that. Just going off of that, you had mentioned that one of the common myths is that, people could swallow their tongues. Are there any other common misconceptions around seizures or epilepsy that you want to elaborate on or
Yeah.
disprove?
I mean, some people, I think it's less and less so, but some people think of seizures as being contagious. Um, some some people, when they hear the diagnosis of epilepsy, they think of it being related to intellectual disability or something, someone having, other developmental disabilities or motor disabilities. Obviously, in our children that have those disabilities, they are at more risk for seizures, but there is a lot of neurodevelopmentally normal kids that have epilepsy.
Right. Okay, so let us say that we have now a confirmed diagnosis of epilepsy. What are things that parents or family members can do to keep, let's say, the house safe for children with epilepsy?
Mhm. I think one thing that I think about is, especially when children are prone to having seizures in their sleep, making sure that their bedside table it has more rounded corners. I know it's a simple thing, but head injury is a common thing that can happen, and maybe having a carpeted flooring as opposed to a hard surface. So just thinking of how to almost safety proof your house in a sense, uh, and the scenarios that can happen depending on the seizure type. So every kid will have a different seizure type. So your response has to be gauged based on that. Um, so safety proofing the house from that perspective, from that angle. And Epilepsy Foundation has a great resource around that.
Okay, thank you for that. So if we are trying to ensure, that we safe-proof the house
Mhm.
or the school or whichever setting it is that the child is in, how do we balance that against um, you know restricting the child, if you will,
Mm.
because they might feel that you're being overly protective, and there's that childhood rebellious kind of. So how do we balance that and make the child not feel like we are hampering them?
Mhm. Um, I would say that one thing to keep in mind is the majority. So it has to be a nuanced discussion. That's why I'm kind of hesitating giving one recommendation or another. So let me give extreme examples. So in a child that has what we used to call benign Rolandic epilepsy, which is a very self-limited epilepsy that can happen most predominantly during sleep, then the limitations, for the most part, aren't there. Whereas a child that has an epilepsy that is a sudden fall kind of seizure, like an atonic kind of epilepsy, and those are children that we have to set up with helmets because they're that at risk for injury. And then there is the in between. So generally speaking, for the most part, there's really no limitations in children participating in general activities that their other peers participate in. They have to abide by safety precautions that are actually the same safety precautions their peers should abide with, as in wearing a helmet for biking or, these electrical bikes and scooters, etc. And there are certain higher risk or medium risk activities that probably the child would have to have established good seizure control for 3 to 6 months, maybe to a year, before saying that they can engage in those activities. But for the most part, there is very limited limitations.
Okay. I want to move on to perhaps the emotional aspects regarding this. So if we have a child who has been diagnosed with epilepsy, and I think you touched on this a little bit in terms of the stigma, how do we help children and family members cope with or live with this diagnosis, given that there might actually be stigma around this or misunderstanding around this?
Like, can you reword the question again one more time?
So there, so if we have a child who has been diagnosed with
Yeah.
seizures or epilepsy,
Mhm.
uh, they do have to put in place certain precautions, and when they go out with their peers, other children of their age, then they may have to explain, this is something that they've been diagnosed with.
Yeah.
And there might be the potential for misunderstanding there. There might be some stigma against that, not necessarily by other children, but maybe from family members or something like that. So that would have some sort of emotional impact on the child themselves and perhaps family members as well. So, how do we prepare families for that? How do we prepare children for that?
Right, right. So there's two angles to it. There's how can you engage the external factors to your favor, which you're not always in control of how people perceive things, right? So there's also a level of understanding and accepting that you cannot control all of people's perceptions of the scenario, and focusing more on how to prepare your child to accept their diagnosis and to understand their diagnosis. And I think the first key step is, to be honest, I think the onus in part is on us as neurologists to have that first conversation with a child in an age appropriate or developmentally appropriate manner to empower them with that information. And the parents can further support that by allowing the child to express their concerns, to express some of their fears, to be accepting of that as a parent, because that can be really hard to see your child in that way. And letting them know that at the end of the day, this, surge of electrical activity is usually temporary for most developmentally normal children, and that it is just a matter of, taking the medication and abiding by the doctor's information that we have resolution. And in those that don't, letting, empowering them with the things that they are able to do, and how the diagnosis is allowing them to grow those areas of their self-confidence that if that diagnosis wasn't there, they wouldn't have that opportunity for growth. In terms of the external factors, I think part of it is how we respond to the seizure. So how the teacher responds to the seizure in the moment, I think, is important, and how they communicate what is happening to the students is important, because it is scary. It is very, you know, out of the blue experience when you've never seen it before. and in some ways it can provoke emotions and misunderstandings in children's and teens and the like. So how we respond, how we communicate, I think is a big way of how to reduce stigma.
Okay, thank you for that. Any key take-home messages you want our audience to leave the session with?
I think the key thing is recognizing that epilepsy has no single cause, and the cause is usually unknown. And I think that is important in our day and age where, we have all these technologies and abilities to test things. And even with those abilities, our understanding of epilepsy is still limited, but that doesn't, discourage our ability to treat and to manage and to monitor these patients over time. I think that's important because I feel most of my patients struggle with that idea that there's no known cause for a lot of their epilepsies.
All right, I'm not seeing any further questions in the chat, so I want to take the opportunity to thank you, Dr. Hala, for making the time and for giving us this wonderful presentation. And also thank you to our audience for making the time to join us today. And I hope we see you all in our next session next month.
Thank you.
Take care.